Therapy is first line for PTSD. But what goes on in the session? And how do you prevent PTSD when your patient calls you after an assault or a major accident? Welcome to the Carlat Psychiatry Podcast, keeping psychiatry honest since 2003.
I'm Chris Aiken, the editor-in-chief of the Carlat Psychiatry Report.
And I'm Kellie Newsome, a psychiatric NP and a dedicated reader of every issue. We continue with our coverage of PTSD, inspired by the American Journal of Psychiatry, new review by Ariel Shalev and colleagues from NYU. Psychotherapy is first line for PTSD because it works better and lasts longer than medications. However, there is an exception to this rule: patient preference. And naturally, you're not going to force a patient to therapy if they don't want to go. But clinical trials of PTSD also find that outcomes are better when patients are randomized to their preferred treatment, whether therapy or meds. There are several therapies that work for PTSD, and we'll review them here, drawing from evidence in a Cochrane-style review of 70 studies involving nearly 5,000 patients.
First is trauma-focused CBT. This therapy involves prolonged exposure sessions where the patient re-experiences the trauma in a new way. Now, there are dropout rates sometimes with this therapy because this kind of exposure is bound to trigger anxiety. But hopefully, unlike the original traumatic experience, the therapeutic re-experience of the trauma is going to be done in a structured, graded, and supported way. And it will also be paired with a sense of calm, such as incorporating self-soothing exercises during or right after the exposure. The key thing, I think, when you do this work is that the patient needs to feel in control of the exposure process, not only to prevent flooding, but because, a key part of the original trauma was the feeling of powerlessness, of being out of control over the events. These exposure exercises are prolonged, as the title said, often lasting 90 minutes, and they involve imaginal exposure in the session where the patient recounts the trauma in full sensory details. Outside of session, they work to reduce avoidance of everyday reminders of the trauma, such as slowly getting back on the highway after a traumatic car accident.
Next, and in fact closely tied, is EMDR, or eye movement desensitization and reprocessing therapy, developed by Francine Shapiro in 1987. Like CBT, EMDR involves in-session exposure, but in this therapy, the patient moves their eyes side to side with eye movements, often following an LED device, while recalling the traumatic events. Sometimes hand tapping is used instead of eye movements. The idea here is that physical bilateral stimulation helps connect brain regions that trauma has split apart. You'll often hear that EMDR is controversial, but the controversy is not over whether it works. It is as effective as CBT, and nearly all practice guidelines for PTSD recommend it. The controversy is about whether the eye movements are a necessary part of the treatment, but we won't get stuck on that. We could just as easily argue over whether other common accoutrements of therapy are necessary for the healing. Comfortable chairs, soothing artwork, complicated theories, and weekly one-on-one sessions in an indoor environment. And that doesn't much resemble the real world. Brain spotting is a recent offshoot of EMDR, where the patient looks in a specific direction while recalling a traumatic memory. The specific position is determined by some trial and error, and it is thought to be associated in some way to an area of disturbance in the brain's memory system. Evidence for brain spotting is much more preliminary.
There's another therapy worth mentioning that the American Journal left out: narrative exposure therapy. They might have left it out because the studies here are not as consistent and large, although a meta-analysis that wrapped up 18 of them concluded that narrative exposure therapy does work with a medium to large effect size. Now, in this treatment, the therapist helps the patient develop a more coherent and meaningful story of the trauma. In some ways, this is an exposure therapy, as they're recalling the trauma in session, but the focus here is more on developing an empowering narrative that is integrated into their entire life story in a meaningful way. This therapy bridges the gap between exposure therapies and another avenue for PTSD, which we'll get into next, therapies that are classified as non-trauma focused.
What? How can a therapy for PTSD not focus on trauma? The answer is that these therapies focus on ways that PTSD symptoms are getting in the way of their current life, rather than exposing people to the difficult memories. If your patient is unable to tolerate the intensity of exposure, this is the way to go. Two examples are presence-centered therapy and interpersonal psychotherapy. These focus on solving challenges in the patient's current life that stem from the PTSD symptoms. Challenges like asserting yourself at work or being open in close relationships. Another is cognitive processing therapy, which operates like traditional CBT, correcting the faulty attributions common in PTSD, like overgeneralizations of fear and negative beliefs about the self. These non-trauma focused therapies worked in controlled trials, but there is some evidence that TF, CBT, and EMDR have more staying power. However, they seem to have fewer dropouts. Exposure-based therapies are difficult and challenging. They sound simple, but it takes a lot of experience to develop the compassion and strength to guide people into areas that every nerve in their body is programmed to avoid. Secondary trauma can be part of the cost for therapists who go on that journey, causing some to limit the number of PTSD cases they see in a week.
In the first episode of this series, we talked about subtypes of PTSD, and we might consider military trauma to be one of those subtypes. Actually, military trauma was where the idea of PTSD first came from, so maybe I should say that civilian trauma is the subtype. Well, compared to civilian trauma, military trauma is less responsive to treatment, both to therapy and to medication treatment. The reasons why are not known, but there are many possibilities. For example, most veterans are men, and women respond better to therapy as well as to SSRIs just in general. Veterans go through unique training that bonds them to their unit, but that can also separate them from society and perhaps from therapy upon their return. Also, some PTSD symptoms like hypervigilance and even anger can be functional for soldiers and hence harder to let go of. Veterans are more likely to have traumatic brain injury and more cognitive problems. That's going to get in the way of recovery. And soldiers also have higher rates of ADHD to begin with. Interesting fact. And then there's the problem of benefits and secondary gain. On and on, so many possibilities. In one study, veterans who were undergoing evaluation for PTSD-related benefits did not respond to psychotherapy, while others who were not going under such evaluation did respond to psychotherapy. Finally, moral injury may play more of a role in worsening the syndrome for veterans, particularly in unpopular wars like Vietnam. Still, therapy does help combat PTSD, bringing about around 60% improvement for the average veteran. But dropout rates are even higher for veterans than for civilians, and incomplete recovery is unfortunately the norm, with more than 2/3 of veterans still meeting PTSD criteria after treatment. Non-trauma-focused therapies, like the ones that we just went over to focus on the effects of trauma in your here and now life, those offer a reasonable option for veterans who dropped out of therapy because they didn't do well with the exposure-based techniques.
Time for a preview of the 2-question CME quiz for this episode. Earn CME through this link in the show notes. 1. Which treatment is first line for PTSD? A. Psychotherapy. B. SSRI antidepressants. C. Either psychotherapy or pharmacotherapy. And D. Combined psychotherapy and pharmacotherapy. What about PTSD in children? Therapy works well in children according to a review of 14 controlled studies involving close to 1,000 participants. Among them, trauma-focused CBT has the best evidence for childhood PTSD. In our next episode, we'll look at what the corner pharmacy has to offer. But first, let's see what we can do to prevent PTSD when patients contact us after a trauma.
In psychiatry, we rarely get the chance to implement preventative therapies, but here's a place where you might. Every year, I get a few emergency calls from patients who just experienced a trauma, maybe a sexual assault, a car accident, or they found their loved one dead. Propranolol used to be my go-to med for these cases, but the studies as they piled up have not panned out on the positive side. And the data is more consistent with a newer intervention, a hormone, hydrocortisone. The idea is that hydrocortisone aids extinction learning. In animals, it increases synaptic plasticity and connectivity and BDNF after a trauma, and reduces adrenergic overload. Ideally, you give hydrocortisone within 12 hours after a trauma for a 10-day course. The dose is hydrocortisone 20 milligrams, twice a day for 10 days. Well, I mentioned the mechanisms in the animal models. There are human studies of this as well, controlled trials supporting it. Outside of that, we don't know much about medications that prevent PTSD. We do know that alcohol and benzos probably make things worse after a trauma. But on the other hand, opioids might help prevent PTSD if physical pain is involved in the trauma, as it often is. In several retrospective but controlled trials, patients who received prescription opioids after a trauma had lower rates of PTSD. Psychotherapy can also help prevent PTSD from setting in after a trauma. And here the prize goes to specific forms of CBT. Importantly, the field has moved away from debriefing therapy. That was a once popular educational and supportive therapy that was often given in group or individual form after trauma exposure. But the Cochrane group found that this debriefing therapy didn't work in a 1997 review, very early on. And in some studies, debriefing even seemed to raise the risk of PTSD, possibly because the more vulnerable people felt triggered by it, or people might have felt pressured to talk about their feelings before they were ready to. Remember that having a sense of control is critical to not developing PTSD. A sense that you're in control over what you're feeling, experiencing, and what you're talking about. Many of your patients are not going to start psychotherapy to prevent PTSD after a trauma, but you can still give them sound advice from what we know about prevention. First, avoid alcohol. Bump up the sleep hygiene and do anything that improves sleep quality because poor sleep is a risk factor. Exercise. We know that that's going to deepen sleep and it helps treat and possibly prevent PTSD. Keep a journal. There are studies on that one. And use deep breathing or mindfulness to manage anxiety. I'll often recommend an app to guide them out of sessions, something like Headspace, or there's other good evidence-based mindfulness and other apps that are free. I keep a list of them on my website, chrisaikenmd.com/apps.
Don't avoid reminders of the trauma, but don't rush in so much that you get flooded. Patients need to regain a sense of control here. Most importantly, be around your community, family, friends, and faith communities that support you. Do things that bring you joy and that restore a sense of purpose and meaning, like helping others. If nightmares are a problem, try imagery rehearsal therapy. It's a simple intervention with a big effect size, where the patient recalls the bad dream in full detail each day. but changes the ending in any way that they like. Look to our August 2021 Carlat interview with the founder of this therapy, Barry Krakow. Join us next week where we conclude this series with pharmacotherapies for PTSD. And no, we're not just going to tell you to give everyone sertraline and paroxetine. We're testing a new feature for audio learners. Subscribers to the print edition can listen to the issue, read by Dr. Greg Maltzberg. To hear it, go to the August issue of the Carlat Psychiatry Report and scroll to the bottom of the table of contents. You'll hear updates on augmentation agents for OCD, a therapeutic approach to suicide assessment, transcranial direct current stimulation, and antipsychotic dosing. If you're not a subscriber, start now with $30 off your first year subscription with the promo code PODCAST.
Thanks for watching. Hit subscribe if you enjoyed this content. And to earn CMEs for listening, head on over to thecarlatreport.com/podcast.